Welcome everyone to the eMedica MRCGP AKT High Yield Revision Webinar 3 for the April 2025 exam. Okay. For those that haven't met me before, a brief introduction. My name is Muhibur Rahman. I'm a portfolio GP based here in Birmingham and Solihull, and I've been helping people get through MRCGP and through GP training. It's our 20th year actually of running courses. So what we're going to do today, we're going to go through exam style questions covering important topics, followed by rapid reviews with examples of the kinds of questions that you might get. And we'll cover some clinical, some stats, some admin. So we'll split this into three parts. The first part, we'll do a few questions where I'll show you a question, give you 55 seconds to look at it. Then I'll launch a poll, and you'll use the poll to select your answer. And then I'll go through the answer and explanations after each one. Part two, what we're going to do is we're going to get you used to managing your time. What does it feel like to do questions one after the other without a gap? So we'll do a 10-question mini mock. And again, to optimum timing. So every 55 seconds, they'll move forward. Then part three, we'll talk about how to make the most of the time left between now and the exam, i.e. these last 8 weeks. And then there's a chance to ask questions at the end. So use the chat as you've already been doing to get involved in the discussion, or if you've got any comments. If you've got a question that you'd like myself or the faculty to answer, in joining me today from the core eMedica team to answer questions and deal with queries, we've got Anna Greathead. Please use the Q&A for that. Great. Let's go straight into the first question. So after 55 seconds, I'll launch the poll. Okay, great. I'll stop it there. So there's a split between A, C, and D. These are the three popular answers. Okay. So what we've got here is an example of an audiogram. Now, what's interesting about this one, you'll notice that they've not annotated which is what. You know, what's the red line, what's the blue line? They've not annotated. Whereas in a typical audiogram, that would be the case. They would outline what's been shown where. But that's actually what's being tested here. Okay. So the correct answer is A, that the hearing in the right ear is mostly in the normal range. Okay, the right ear, whenever you have a color audiogram, the standard denotion, the right ear is always the one shown in red. So look, refer red, refer right. This is the right ear. This is the left ear. The blue one is the left ear. So if we look at what's normal hearing, this is the line. Anything above this is the normal hearing range. Okay, so 20 decibels. Below this, we've got sort of mild hearing loss, then it becomes sort of more severe, and then very severe is down here. So if you look at the right ear, the one in red, you see, look, across from low frequency all the way up to high frequency, even here, this is still all normal. Then right at the end, this is like at 7 kilohertz, you've got very mild degree of loss. So do you see that fits, that the hearing in the right ear is mostly in the normal range. In most of the scale, it's normal, okay? Whereas if you look at the left ear, even at low frequencies, there's some loss, and then it gets worse as the frequencies get higher. Okay. What's common with this question is sometimes people mistake this for a conductive hearing loss. And that's why quite a few of you have picked C or D. In a conductive hearing loss, you would be shown both air conduction and bone conduction, and you look for a gap. This isn't a gap between air and bone conduction. This is the issue in one ear compared to the other. Okay, so this is the hearing in one ear compared to the other. And that's because when we have a sensory neural hearing loss, typically they only show you the air conduction because we're not bothered about bone conduction. Okay, if there was bone conduction, it would be shown with brackets, not with a circle or a cross. So what this is testing is understanding how audiograms are normally presented. Okay, so I'll show you what it looks like. if there is a conductive loss. So look, this is mild loss, then it gets worse. This is all normal, all right? So bone conduction shown by brackets, air conduction shown usually one ear with a cross, one ear with a circle. Good way to remember it, air passes through a circle, all right? And then when they're in color, the right ear is always red, therefore the blue one will be the left ear, all right? So look, this is an example of a conductive hearing loss. You see, bone conduction is normal, so brackets in the normal range, and then air conduction is reduced. In this case, it's bilateral. In both the right, the red one, and the left, conductive loss is there because the air conduction is reduced in both. But look, the bone conduction in both is normal. In a sensorineural hearing loss, they typically don't bother showing you the bone conduction because we don't care about it. Okay, they just show you the air conduction like this. Anyone want to type into the chat what type of sensorineural hearing loss is shown typically by this pattern with this sort of frequency where there's a significant reduction? Yeah, this is very typical of presbycusis, the hearing loss of old age, which is the most common type of sensorineural hearing loss. Okay. Let's move on to men's health. Okay, great. So the split for this one was between B and D predominantly. They're the two popular answers. Now, this is an example of a two-step question. The question is asking about management, right? And the most suitable management, getting that right, is what's going to give you the mark. But to get that right, you first need to understand from the description and the key features they've described, what's the likely diagnosis? Because that's going to lead you to the right management. Very commonly, where you get the diagnosis wrong, you're going to get the management wrong and not get the mark. So let's do the first part of the learning first. Type into the chat, what do you think is the likely diagnosis? Like imagine instead of asking these options and asking this question, it said, what's the single most likely diagnosis? From the description here, what's the single most likely diagnosis? Okay, so some people have said UTI, some people have said prostatitis. Most people have said epididymoorchitis or orchitis or epididymitis. Okay, so that's the most popular answer, and that's actually the correct answer, right? So now within that, there's a couple of variants. Okay, and getting the specific diagnosis, so i.e., that it's likely to be epididymoorchitis, but in this particular patient's case, that they've not been sexually active recently, so it's less likely to be an STI as the causative organism, is going to give you the right answer. So the right answer is D. Treat with levofloxacin, and that's once daily for 10 days. Okay, I'll come back and show you something important here, where sometimes people read part of the answer, and then even if you've got the knowledge, you can still lose marks because of exam technique. This is really important to pass the exam, that you need both the knowledge, you've got to have that, that's the base, but then exam technique can make a huge difference to how you actually perform when you get asked a question in the exam. Okay, so they've recently had a UTI, and that means that there's certain organisms that are more likely compared to if they'd recently had an STI and he's not been sexually active recently. And then the other thing that is useful is the fact that Pren sign is positive. All right, so sometimes people think that it could be torsion, and that's why some of you would have picked A, admit to hospital for surgical management. But in torsion, Pren's is usually negative. All right, so that's how we could eliminate that one. So how does epididymoorchitis present? comes on gradually, and what happens is they've got pain, there's tenderness, usually there'll be a swelling, it's usually on one side, there'll be erythema overlying the swelling, and then a very useful clinical sign is PRENS. So this is where you elevate the scrotum, thereby elevating the testes, and that relieves the pain. In torsion, elevating the scrotum and elevating the testes will not relieve the pain. In fact, that's often so painful, they won't even let you try to elevate, they won't let you touch it, because the minute you try to touch it, it hurts so much. That's actually a useful clue to torsion, okay? So how do we manage it once we've got the diagnosis? Well, if you've got a patient who's septic, really unwell, you might need to admit them because they might need IVs. But otherwise, we can either refer for them to be seen in GU clinic if they can be seen within 24 hours, or if that's not possible or they don't want to go, we can treat it in GP. And you treat it based on the likely cause. So if they've been sexually active recently, or they've got symptoms that make you think of something like gonorrhea, for example, then you treat it based on the fact that that's the likely causative organism with something like ceftriaxone. Okay, with doxycycline, you might have azithromycin as well if you thought that sometimes you might want to cover for chlamydia as well. If they're not recently been sexually active, or it's less likely that it's an STI variant, then the other common is an enteric organism. If they recently had a UTI, like this patient, or they're low risk for STI, then you can either use ofloxacin or levofloxacin, okay? Now, both of these are long courses. So levofloxacin is 10 days, ofloxacin is 14 days. If I go back to the answer options, so I mentioned that one of the other popular answers was B. Now, if they had an STI, then that would fit. And then sometimes people pick C. Now, ofloxacin is a valid treatment, but not as a single dose. You see, you've got to read the whole answer, not just the first part. If you just see this bit and think, oh yeah, I've read about that, you can use either one of these. You might not even read this far. You might select this one, but it's not a single dose treatment. It's a 14-day treatment. On top of that, it's twice daily. So actually it's 28 doses in total, isn't it? All right. So that's why D is the correct answer. Let's look at antibiotics in sore throat. Okay, so I'll stop it there. There's a split, almost equal, to be honest, between A and B. No need for antibiotics, offering a delayed script. And then a few people picked either C or D. No one picked D, right? So again, there's sort of two parts to this. And a lot of the high challenge questions in the exam, they are two-part questions or two-stage questions. So can you see that it's asking you what the most suitable management is according to the fever pain criteria. So the first part is, yes, you've got to know the guideline, but you've got to be able to interpret from all of this information, what is this patient's fever pain? And again, that could be the question. It could ask you, what's the patient's fever pain? And the options could be 0, 1, 2, 3, 4, 5, okay? So type into the chat, what is this patient's fever pain score? Again, if you get this part wrong, it might lead to you getting the wrong management. Okay, so we've got answers here ranging from 0 is the lowest I've seen, 4 is the highest I've seen, but people have put 1, 2, 3, a big range. The most popular answers are 2 and 3. And the correct answer is 3. This patient's fever pain score is 3. And that's why the correct answer is B. Offer a delayed script. Those of you that thought it was 1 or 0, that's probably why you picked A. Advise no need for antibiotics, because if the fever pain score is 0 or 1, that's what the guideline recommends, that they don't need antibiotics. That's because the likelihood of it being strep, if it being bacterial, are very low. Whereas if it's 2 to 3, there's a moderate probability, which is why the guideline recommends that you could offer a delayed script. If it's 4 or more, then it's a high probability and you should consider starting antibiotics that day. Okay, so why have they got 3? Well, they've had a 2-day history. What's the time period? The A in fever pain is for attending rapidly. Within how many days of the onset of illness? When they first started symptoms, within how many days would I have to present? Within 3 days. Yeah, excellent. Well done. So can you see they've come within 2 days, so that's within 3 days. So they get a point for the A. All right. Mother says that they had a fever of 38.1 earlier today. On examination now, they're afebrile. Do they get a point for that? Yes, they do. It's fever within the last 24 hours, and that includes if it's been measured at home. It doesn't have to be the fever that we've measured. Okay. Most people with children in the house will have a thermometer in the house. Okay. So they get a point for that. That's the fever part. It's knowing that it's fever within the last 24 hours and that it can include self-measured or self-reported fever. Okay. And then finally, the fact that the tonsils are inflamed, you get a point for that. Okay. So that's 3. Can you see? They've got a runny nose, so they don't get a point for the N. The N is no cough, no coryza. If they have either a cough or a runny nose, cold-like symptoms, they get no point if they get either one. If they don't have a cough and they don't have a runny nose, cold-type symptoms, then they get a point for the N. Okay? And then the P is pus on the tonsils. There's no pus visible, just inflammation. But you do get a point for inflammation. That's why it's 3, okay? And so the guideline translates to 2 to 3, consider a delayed script. Okay, so that's the summary of it, right? Score 0, score 1, low probability of it being bacterial, don't give antibiotics. 2 or 3, moderate probability, you could consider a delayed script. 4 or 5, high probability, think about giving antibiotics that day. First line, if they've no allergies, is PenV, which is a 10-day course. If they're allergic to penicillin, then you can use clarithromycin or erythromycin. Those are a 5-day course. Someone's asked a really good question. Can you use the Centaur score? Yes, both are mentioned in the NICE guideline as suitable decision-making aids. However, this question specifically asked for the management according to the fever pain criteria. Okay, and so you need to answer it according to that. But you should learn both. Question number 4. This is the admin domain. Okay, great. So the 2 popular answers are C and E. So the Data Protection Act 2018 and the Access to Health Records Act 1990. Okay, so the key thing to this is that this patient doesn't want to access their own records. They want to access their father's records, and their father's passed away, and they've got a legitimate reason. So look, they're the next of kin, and they're the executor of the will, and there's a reason why they want access. They think there's been negligence, so they're thinking about legal action. So the correct answer is E. That if you want to access someone else's records who's passed away, and you've got a legitimate reason to do so, then you apply under the Access to Health Records Act 1990. For those people that picked C, you can't use this one to access someone else's record. When would you use the Data Protection Act? If you want to access your own information. Okay, so let's say I wanted to access information that was held in my GP record, my GP practice, where I'm a patient. Then I could apply, it's called a subject access request. So I could put in an SAR to my practice to say, look, I'd like the information held in my record. And then they've either got to give me access to the information or give me a copy of the information. Okay, but that is used to use to access your information. They're not trying to access their own information. If you want to access someone else's information, this is the act for that. and you need to be either the next of kin or the executor of the will or have permission. So 3 key pieces of legislation in relation to health records. So the Data Protection Act 2018 is what we use to access your own information. You can also apply under the GDPR, the General Data Protection Regulation. If a company wants to access information about their employees, usually in relation to occupational health issues, then they can apply under the Access to Medical Reports Act. And then if you want to apply to get access to information on someone who's passed away and you have a legitimate reason to do so, then you apply under the Access to Health Records Act 1990. Okay. Right. And then the evidence-based practice, sometimes described as the stats domain. Have a look at this question. Okay, great. I'm happy to see that most people have got this one right. But for those that haven't, we'll look at why you might get this wrong. Okay, so this is an example of one of the new style data interpretation questions that they're using real life data from, in this case, Public Health England, rather than a published paper or a study. Okay, so the question is asking which area had the worst mortality rate, specifically for women under 75. So if we look at the table here, you can see this is mortality rate from all causes for persons. This includes male and female. This is just for men, and this is just for women. So, first thing is to make sure you're looking at the right line. Okay, we're looking for this line here, women under 75, and mortality means death for any reason. Okay, as you can see here, this is a subset of this data, which is deaths that are specifically attributed to a cardiovascular disease. Maybe they had a heart attack, maybe they had heart failure, maybe they had, some other related cardiovascular disease. They might have had AF and then had a clot and had a stroke, for example. Okay, that would still count as cardiovascular. This could include cancer deaths. It could include someone that died, in a car accident, so trauma, anything. All right. So once we've got the right line, then it's just a matter of looking. These are deaths per 1,000 population. So the correct answer is D, Doncaster. Okay, so if we look at the right line, there's no maths, there's no formulae, you just have to read the numbers. As you can see, Doncaster had 324 deaths per 1,000 people. That's higher than anywhere else. The second highest was Barnsley. Okay, now why might people have picked Bradford, which was the second most popular answer? So if you look at Bradford, if you were looking at men and women, so persons, you can see Bradford had the highest rate. If you looked here at men, again, Bradford had the highest rate. If you looked at the wrong line, you're going to get the wrong answer. Similarly, if you looked at female, but you were looking at just cardiovascular disease instead of what did the question ask? It just said worst mortality rate. That's this line. Okay, that's exam technique. Reading the question carefully and understanding what's being asked of you. Because if you looked here, again, you might see that Bradford had 65.6. Doncaster had only 51. Okay, it wasn't even third because you've got Barnsley and Calderdale all had higher rates than Doncaster if you look at just cardiovascular disease. But if you look at all-cause mortality in women, which is what the question was asking, you can see that Doncaster had the highest, 324. Okay. Some of the other kinds of types of data interpretation that you want to get familiar with include all of these things. So prescribing data, incidence is what we looked at there, but prevalence of different types of disease. Other types of public health data, which might include things like cancer data, age bands, the demographics in different regions or in different practices, mortality rates for infants, mortality rates, specific disease, and then interpreting research. So, graphs, charts, and how to interpret them. And some examples. This is looking at different age bands in a particular practice compared to the area. So clinical commissioning group, the area, this is in West Midlands. This is data actually pulled from a practice where I work as a locum on and off. And then England as a comparator. This is looking at prescribing data for a practice, angel surgeries in London. And it's actual real life data. And broad spectrum antibiotic prescribing is often used as a quality indicator. This is looking at age bands in 5-year groups for male and female patients for a specific practice. This practice is in Manchester. And then this is looking at infant mortality. Okay. But then, interpreting research. So this is called a leaf plot. It looks at pre and post-test probability and how that's impacted by test results. This is called a Kate's plot, sometimes described as a smiley face graph. It's a visual way to represent risk, but there's lots of other things you can calculate if you understand a Kate's plot. Okay. Right, so that's the first section where we were going to do, we've done some clinical stats and admin question. Okay. Any questions before we move on to the mini mock? We're going to do 10 questions. Again, some stats, some admin, some clinical, all in one go. If you have, put them in the Q&A. I can see Anna's already started answering some of those. But just to let you know that we have, if you found that type of learning helpful, we do a question at a time, then immediately after we'll go through answers, explanations, and look at why you might have got it wrong if you didn't get the answer right. A review of the guideline, but also a focus on technique. Then our AKT Masterclass webinars are coming up in April and at the early part of April. These basically work in that way. Each one, we go through 50 questions, but cover more than 60 topics. So we've got a half day covering 50 stats questions, but more than 60 stats topics. We've got a half day covering all the key admin topics. Again, 50 questions, more than 60 topics. And then we have 2 long evenings, 3.5 hours each, covering 100 clinical topics, but they're all topics mentioned by examiners in recent examiner reports. These are things that are often retested, why we call them the high yield clinical crammers. Okay, so 100 questions across 2 evenings, 50 questions each evening, but over 120 topics we'll cover. Because sometimes after doing one question, I might talk about several related topics. So statistics is 4 hours, admin is 4 hours, high yield clinical crammer 1 and 2, 7 hours across 2 evenings. You can book any one on its own, or if you book all 4 of them, it's £299 for all 4, which is a big saving compared to booking them separately. And if you book the live session, you also get access to the recording for a month afterwards. Those of you in our Pass Guarantee program, you're already registered for all of these. Okay. So these are some of the topics covered in the stats. And we've had a lot of people who previously hated stats, and they might not love it afterwards, but they at least feel confident in it. And we've had lots of people who ended up with 100% in stats, or 95% in stats, or 90% in stats, 100% in stats. This can make a big difference, because if you can get a really good mark in stats and admin, you can get away with 70% or so in clinical. Okay. And then the admin one will cover all of these. Again, lots of people that admin topics very boring, but if you learn the topics, the questions are actually quite straightforward. So you can get a good mark. 95% in admin, 95% in admin, 90% in admin, 95% in admin. Okay. And then the high yield clinical crammer 1 and 2 will cover 100 questions across 2 evenings. These are some of the questions that will be covered. Okay. But over 100 topics. All right. So time for the mini mock. So we're going to do 10 questions. The questions will move forward automatically. I won't launch any poll for these. Just write down your answers at home with the question number. After you've done all 10, I'll then go through the answers, explanations, and the teaching, okay? So I just want you to get used to answering questions one after the other, and having to, sometimes you get a question that you struggle with, having to clear your mind and cope with another question without having a break while we go through the explanation, okay? So here we go. Good. So let's go to the answers, explanations, and teaching. So if you mark your own, you get 1 mark for each fully correct answer. Okay. So first one, remember, we already did 5 questions earlier. That's why we started on 6. So we do 15 by the end of the session. So this is a very typical area for questions in the exam. Every AKT has to have at least 1 drug calculation question. In many exams, there'll be more than 1. So they'll often have a pediatric one and then a palliative care or cancer management, sort of analgesia type one. So this is very typical of that. Okay, so what we've got is someone who they're taking 240 milligrams in total of morphine. Can you see modified release morphine, 120 milligrams BD, that's 240 in total. They're well controlled. The reason they can't take orals anymore is progression of their esophageal cancer. They can't safely swallow anymore. This is a very good candidate to therefore change over to a non-oral medication. And if they're in the sort of palliative phase, quite often what you'll see is that a syringe driver, especially someone that's near the end of life, a syringe driver is often used. Okay, so what's the right dose? That's the question. The correct answer is 80 milligrams over 24 hours. And that's because the conversion from 240, when you've got oral morphine, if you're converting to a syringe driver and putting diamorphine in it, you just divide by 3. Okay, that's the conversion recommended in the BNF. So you can see 120 milligrams twice daily, that's 240. The conversion factor is 3. So divide by 3, that's 80 milligrams over a 24-hour period given by a continuous subcutaneous infusion. That's the formal name of how a syringe driver is given. Okay. Now, common mistakes with this is people miss 120 milligrams twice daily. So they just look at the number 120. So they divide that by 3. They know the conversion factor is 3 for diamorphine. So then they will pick 40 because they missed that it's twice daily. And the other common mistake is people don't know the conversion factor. So what they do is they divide by 2 and they end up with 120 milligrams. That's the conversion factor if you're changing oral morphine to morphine by injection, not diamorphine. Diamorphine is 3 times as strong as oral morphine. So if we look at, use of syringe drivers in palliative care, if you're changing from oral medication to a syringe driver, this is the conversion table adapted from the one in the BNF. So what you do is you look at their 24-hour oral morphine requirements, and that should include any breakthrough doses. And then if you're converting to morphine given by syringe driver, because you can give morphine or diamorphine in a syringe driver, for morphine you divide by 2. For diamorphine you divide by 3. So look, someone was on a total of 240 milligrams, like this patient. If you're changing that to morphine in a syringe driver, you divide by 2. It'd be 120 milligrams of morphine in 24 hours. If you're changing to diamorphine, it's 80 because you're dividing by 3. Or another example, if someone was on, say, 60 milligrams modified release twice daily, so they're on 120 in total. If you're changing that to morphine, that would be 60 because you're just halving it. If you're changing that to diamorphine, you'd be dividing by 3, so that would be 40, and so on. Okay, question 7 is one of 2 extended matching questions in a set. Okay, just like this, in the real exam, all questions have a title, and extended matching questions, they come in sets of 2, 3, 4, or more, where the answer options stay the same. So you'll see genetics 2 of 2 will have these same options, but the question will be different, right? So the key thing here is knowing what hemochromatosis, what's the inheritance pattern of that? How's that inherited? Autosomal recessive. Okay, great. So if they're both carriers, i.e. they've both got one abnormal gene and one healthy gene, what's the risk that the children that they have actually have the disease, not become carriers like them, but have the disease? It's 1 in 4. Because they'd have to get the hemochromatosis gene from mom and from dad. There's only 1 in 4 chance that you get the abnormal genes from both parents. Okay. And so this is 2 of 2. Answer options have remained the same. The question has changed. In this case, not that much. Same scenario, but now they want to know what's the risk that their children are like them and become carriers. The risk of becoming a carrier if both your parents are carriers for an autosomal recessive condition is 50-50. Okay, and if I show you visually, it's much easier to understand. So look, here's mum. She's got a hemochromatosis gene, that's the H, and a normal gene or healthy gene, that's the N. Dad's the same, a hemochromatosis gene and a normal or healthy gene. So you get one from your mum, one from your dad. So if you look at all the possibilities, you could be unlucky and get the hemochromatosis gene from mum and from dad, HH. This has got full-blown disease. There's only a 1 in 4 chance of that happening. You could get one hemochromatosis gene from either parent and a normal gene from the other. There's a 50% chance that happens. You're a carrier. You could pass it to the next generation. You may have some mild symptoms, but not full-blown disease. And then you could be lucky. You could get the normal gene from mum and the normal gene from dad. There's a 1 in 4 chance that happens. If this happens, not only will you be healthy, not have symptoms, but you can't pass it to the next generation. Okay, so that's how autosomal recessive inheritance works. All right. So if both parents are carriers, there's a 50% risk that any children will be carriers, 25% risk that they get both abnormal genes and have full-blown disease, and a 25% chance that they get both normal or healthy genes and become healthy non-carriers in the next generation. Okay. It's also worth knowing the modes of inheritance of some of the relatively more common or more important for the UK population diseases. Okay, and I've listed them here. And don't forget the chromosomal disorders. So trisomy 21, we've got an extra one at position 21. Turner's 45X, so you should have 46, right? The O means 1 missing. That's a deletion. Klinefelter's an insertion, you've got an extra one, 47XXY. Okay, oligomenorrhea. Now, this is a challenging question for 2 reasons. It's both a multiple best answer. You can see it says which 2. Most questions don't mention how many options to pick, so there's only 1 right answer. If there's more than 1, they will say clearly how many you need to pick. So you can see it says which 2 of the following would not be recommended. Now, what makes it challenging is not just is it a multiple best answer, and those are marked very strictly in the AKT. So you have to get both right to get 1 mark. If you get 1 right and 1 wrong, you get nothing. There are no half marks in the AKT. But this is also negatively framed. It's saying which 2 of these would not be recommended as part of the diagnostic workup for this patient. Okay, and so in this case, can you see that the negative word, the not, is in bold, and sometimes it'd be highlighted like this, sometimes it'd be in capital, sometimes it'd be underlined. Sometimes though it won't. So it's really important to read the question carefully. One thing to note though, there are very few negatively framed questions in the exam. The majority of questions in the AKT are positively framed. They'll ask you, what would you give, or what would you do? What is the right test? What is the right diagnosis? But you might get a handful in your whole exam of 200 questions. You might get a handful that are negatively framed. Okay, so can you see, if it's asking what would you not do, which 2 of these would you not do as part of the diagnostic workup for this patient, you want to look at these symptoms and work out what is the diagnosis that you're looking for. So type that in the chat, because that could be the question, right? Could I give you the same symptoms and presentation and could ask you what's the single most likely diagnosis? Okay, so some people have said PCOS, some people have said premature ovarian failure, some people have said menopause. Okay, yeah, so what we're looking for, the diagnosis that we're looking for, look at the age here, they're 38, is premature ovarian insufficiency or premature ovarian failure. 2 different names for the same thing. That's very different to PCOS. Okay, so which 2 would not be recommended? If we look at the guideline, the 2 that would not be recommended, pelvic examination is not recommended, and AMH testing is not recommended. Now, most people pick AMH, but a lot of people, for their second option, they pick one of the other ones. If you've got 1 right and 1 wrong, you don't get anything. There are no half marks in the AKT. Okay, so if we look at the symptoms, as I said, that age is very important. So she's under 40, and that's one of the things that will make you suspect premature ovarian insufficiency, is that they're under 40 and they're having menopausal symptoms. Okay, so they may have some of the typical menopausal symptoms like vasomotor symptoms, hot flush, but they may also have erratic periods. So if you look at this patient, periods rather than every 4 or 5 weeks, 6, 7, 8 weeks, then they stopped completely, then they've spontaneously restarted. But she's also got some of the other symptoms that you can see. So mood changes, and then otherwise healthy. All right, so A and H are needed to get the 1 mark. So when to suspect premature ovarian insufficiency, also known as premature ovarian failure. So under 40, they're not on the pill, they've got menopausal symptoms, and that could be changes with the periods. It could be some of the other symptoms. And then in terms of testing, the FSH is raised. So the threshold you're looking for is 30 international units per litre 2 different samples at least 4 weeks apart. Other things that you might do as part of the workup: LH, estradiol, prolactin, thyroid, testosterone. But the guideline specifically says not to routinely do a pelvic examination and not to use AMH testing to diagnose. Right, this one's from the admin domain. So it's about GMC guidance. All right. So we've got a situation here where there's a gift voucher being given. And again, it's a multiple best answer. So which 2 of these statements are correct? They are B and F. So if someone voluntarily gives a gift, that could be a patient or a relative, in some situations you can accept those. Some people have it in their head that you can never accept a gift in any situation. That's not based in any fact. They've made that up themselves. The GMC has never said that. The GMC has rules on when we can and can't accept gifts, okay? And there is no maximum value set by the GMC of a gift that can be accepted. Why might some people pick E? Because nothing to do with the GMC, but if you work in a GMS practice, GMS is General Medical Services. It's the most common type of NHS GP practice, okay? That contract has a rule within it that if you accept a high-value gift, and they define a high-value gift as a gift worth £100 or more, you need to record that in a register of gifts that's held at the practice. But see, this question has nothing to do with GMS guidelines. It's to do with GMC guidance. Again, sometimes people misread this. That can also lead to getting it wrong. So the correct answers are B. Sometimes you can accept gifts as long as it's been given voluntarily. It says in some situations, there are some additional rules which I'll cover now. And the GMC doesn't set any maximum value, okay? So what they say is that you can't encourage patients to give you gifts. You can't pressure them to make donations, even if it's to a charity or other good cause. You're not allowed to alter the management that you offer or the services that you provide based on gifts, because then it's a bribe. And you shouldn't accept a gift if it might be seen as you're taking advantage of them or conflict of interest. You know, if you've got a patient with dementia, for example, don't accept a gift from them. They might feel they have to give it to you. They might have given it voluntarily with capacity, with understanding what they're doing. But, you know, if you've got a patient with capacity and none of those apply and they offer it out of their own choice, you can accept it. And the GMC doesn't state any maximum value, okay? And those of you that are working in GP or worked in GP around Christmas time, you see it's very common, especially patients that have been with the practice for a long time and they have a regular GP they see, it's really quite common that they will drop off a gift, okay? Whereas if you happen to work in a GMS practice, then alongside, you know, we all have to follow GMC guidance, right? We are GMC registered doctors. But if you're working in a GMS practice, then you have to uphold the provisions in the GMS contract. That's got nothing to do with the GMC, therefore nothing to do with this question. But that's a separate thing that you could also be tested in. That has a stipulation on it that if you accept a gift worth £100 or more, you have to record that in a register of gifts, okay? Right, rheumatological disease. So what do you think the diagnosis might be? 48-year-old lady, persistent synovitis, small joints of hands and feet. Yeah, would be worried about rheumatoid, right? So given some NSAIDs for analgesia, order some blood tests to start doing a workup. So what's the appropriate next step? Correct answer, they should be seen within 3 working days, or referred to be seen within 3. Why? Because this is one of the very high risk. So all patients with suspected rheumatoid should be referred to be seen within 3 weeks. But if they've got very high risk features, and for this patient, it's the fact that the small joints of hands and feet are affected, that's one of the very high risk features, then it's 3 working days rather than 3 weeks. So what are the other very high risk features? So anyone with suspected rheumatoid, they should be seen within 3 weeks. Who to refer even more urgently? Small joints of the hands or feet, multiple joints, or they've already had symptoms for at least 3 months by the time they present. The reason for that is at that point, they're likely to have significant disease progression. So the sooner they get seen and get put onto disease-modifying anti-rheumatic drugs, the more likely that we can improve their outcomes, okay? So, you know, while you can start doing the bloods, don't wait for the results and delay the referral because of that, okay? Alcohol intake. So how many glasses of wine does this patient drink in a week? That's the first part of getting this question right. Okay. 9, right? Because 7 nights a week, they have a glass of wine. And we're told it's a 250 ml or large glass, and it's a standard strength for wine, about or medium strength, about 12% alcohol by volume. But you see, on Saturday and Sunday, they also drink another glass with lunch because they're not at work. They're teaching Monday to Friday. So they're only drinking in the evening. You see, so that's the first bit, is reading carefully, because it's easy just to look at the number. This is in the description rather than a number just given. So 9 glasses of wine. And there's 2 ways you can calculate then the units. One is if you just know that a large glass of wine of medium strength, which is like this, is 3 units. You can just do 9 times 3, which is 27. You can do that in your head. Okay. So large glass of medium strength wine is about 3 units. Roughly 9 times 3 is 27 units. The other way is to be precise, is to use the formula. So units of alcohol is volume in milliliters. So that's 250 milliliters. Multiplied by the percentage alcohol by volume. So that's 12%. Okay. So multiplied by 12. Take that total divided by 1,000. That gives you 3. I'll show you the calculation. Okay. So 250 mils times 12%, 3,000, divide by 1,000, gives you 3 units. Okay. And then multiply that by the number of glasses, which is 9. So you get 27. So common mistakes here is if people only saw the 7 and they didn't see the other 2, then you often get 21 because you're doing 7 times 3 instead of 9. That's the common mistake. And this is how many units are in different types of alcohol. So that sometimes it's easier just to estimate, and that's quicker in the exam. But if you want to be precise, this is how you do it. That's the formula. Take the volume in milliliters, multiply by the percentage alcohol by volume as a whole number, as in 3, 4, 3.5, rather than a fraction, and then divide that by 1,000. Okay. And then something else that's worth knowing, because sometimes I would describe it how a patient would say. So a patient might say, I have 3 pints of lager. Okay. They might not tell you how many milliliters. How many milliliters is in a pint? They'd expect you to know that. Because we use imperial measures for some things in the UK, and we use metric for others, right? So 1 pint is 568 milliliters. Okay, 568 milliliters. Okay, question number 13. So we've got someone with poorly controlled diabetes. Look, HbA1c is 70, way above target. All right. If someone's on multiple drugs, what's the target? What do we want it to be? Generally, 53 is the target. Once it goes above 58, you want to move to the next stage. So they're well above target, and they're well above the level where we would move up a step, okay? Because they're at 70. So that's why now we're thinking they're already on triple therapy. We're thinking about insulin now. So what would be a suitable regime? Keep them on the metformin and put them on an intermediate insulin, like NPH, neutral protamine hagedorn. This is derived from a fish protein. So typically what I would do is I'd keep them on their metformin, the same dose they were on in the day, and I'd put them on a once daily that they take in the evening, NPH insulin. Some patients, if that's not enough, you might move to twice daily. And then if they're really poorly controlled, you might need to have a baseline and then also give them a fast-acting insulin, around the time of meal times, for example. Okay, so NPH and the short-acting insulin, you might skip straight to that. If the control was even worse, it was 75 millimoles or more, the HbA1c, you might skip straight to that. Then when might you consider a long-acting insulin like Detamir or Glargine? If they need help with injections, or if they keep getting hypos that make them symptomatic. And it's important that they monitor their blood sugars. Generally, they'll do that twice a day, so morning and evening. And if they're not well controlled, this is when you might need to also have a shorter acting insulin around meal times as a top-up. Okay, type your answer into the chat for this one. This is from the evidence-based practice domain. And this is an example of a free text question. So these questions in the exam, when you get them, there are no options to pick from. There's no A, B, C, D. You will type with the keyboard your answer. Now here, there's a bit of technique here, because they've asked you to type it to the nearest whole number. But they've also asked you for the incidence per million, and that's because that's what the World Health Organization asked all countries to report their incidence in, so that we could standardize and compare. Okay. So we've got answers ranging from 4, 4.16, 24, 42 to 41,560. Big range, okay? The right answer is 41,560, okay? So let's look at how that works, right? So if you type this, you'd get the answer. If you put the comma or you didn't put the comma, it's okay. You'd get the mark. You put anything else, you wouldn't get the mark. So for those of you that put a percentage, when it asks you to do it per million, percent is per 100. That's what percent means. Percent is 100, okay? So percent just means per 100. But they've asked you to do it per million to the nearest whole number. So let's do the calculation. First of all, incidence, all right, is number of new cases divided by the total population. So here are the cases that we had, and this is the total population. So if you do this number divided by 66,650,000, that was a population at that time. We're about 70 million now, 5 years later. That gives you this number, 0.041, etc. Those of you that then multiplied by 100, you would have got 4.1, which the nearest whole number is 4. Okay, it's 4% roughly. But they've not asked you to calculate as a percentage. They've asked you to calculate it per million because that was how the WHO asked countries to record. So therefore, instead of multiplying by 100, in that last step, you need to multiply this number by a million because it's per whatever. If it's per 100, you multiply by 100, that's percent. Per 1,000, you multiply by 1,000. Per million, you need to multiply by a million. So when you take this and multiply by a million, you get 41,560.39. So how do we round this to the nearest whole number? We look at the first number only after the dot. If this number is 5 or higher, you add 1 to this number. So it would be 41561 if this was 41560.5 or more. But because it's 4 or less, in this case it's 3, this number is irrelevant. Okay, you just look at the first digit. The nearest whole number stays at this, so you just drop the dot, so it's 41560. Okay, so that's why it's 41,560. So just to recap incidence. Incidence is the rate of new cases of a disease. So, in some cases, you might report it as a percentage. Percentage is just per 100, okay? Or you might report it as a different proportion of the population, i.e. instead of per 100, which is what percentage means, you might report it as per 1,000 or per 100,000 or per million. Especially for rarer things, you'll often see they'll report it as per 100,000, for example, or per 10,000 or something like that. Okay, so all you do is take the new cases, divide it by the total population, take that number, and then if it's a percentage, multiply by 100. If it's per 1,000, multiply by 1,000. If it's per 100,000, multiply by 100,000. If it's per million, like this case, multiply it by a million. Okay, last one. So we've got someone second trimester, and they've been using paracetamol. That's not helped. Now they've gone on to ibuprofen because they've got a sprained ankle. So what's the right information to tell them about NSAID use in pregnancy? Correct answer is D. That actually, if someone's used beyond week 20 NSAIDs, then they might need additional monitoring. And that's because of a recent MHRA alert. Okay, the MHRA is the Medicines and Healthcare Regulations Agency. They both license medications to be used, but they also monitor. So, when you fill in the yellow card because someone's had a really bad anaphylactic reaction to a drug or something like that, for example, that goes to the MHRA and they pull data from all of these different yellow cards and incidents, and then they work out, oh, there's a pattern. We're seeing, more of this side effect, and every so often they'll put out an alert. So they put out an alert late last year about NSAIDs because historically we used to say, look, don't use them beyond 28 weeks because of all of these risks. Okay. And it doesn't matter if it's injection or if it's oral. Essentially, it's a class effect. So, pretty much any NSAID. But the latest data highlighted increased risks when they've used it for a significant amount of time beyond 20 weeks. And so that's why the new advice is that, if they're using it beyond even 20 weeks, because it can lead to reduced fluid, that's secondary to impacting the fetus's renal function. And that it can also lead to constriction of the ductus, which can lead to heart dysfunction. That if anyone has been exposed to NSAID for several days at 20 weeks or beyond, we should consider additional monitoring. to look for the levels of fluid, and that we should avoid prescribing and should advise them not to use over-the-counter NSAIDs 20 weeks onwards now, not 28 weeks onwards. Okay. And it's worth looking at not just that MHRA report, but others. And we recently had a GP update looking at different MHRA alerts. You can find that on our YouTube channel. Okay. So add up your score. You get a total out of 15, the 5 that we did in the first session, the 10 that we did in the second session, and then I'll tell you how to interpret that, and then we'll wrap up. 11 or more, that would equate to a pass. If it's 11, it's just about pass, okay? 10's borderline. In some exams, this would be a fail. In some, it would just about make it to the pass. So it's borderline. And 9 or less, that's not there yet. But whatever you scored, don't worry. You're not sitting the exam tomorrow. You're sitting the exam. It's actually exactly 7 weeks from today, the exam. Okay. So that's a good amount of time to identify which bits of the curriculum are not finished, to make sure you finish them. Identify gaps in knowledge. There might be some things that you read, but maybe you didn't pick out some of the finer detail. And more importantly, to work on your exam technique. Some of the questions that you got wrong here, you actually had covered the topic, you might have had the knowledge, but maybe you missed something important in the question. You missed something important in one of the answer options. So, for example, you read part of the answer option rather than the whole thing. That's all part of exam technique, okay? And that can make a big difference by the time you get to the exam. So in terms of revision planning, the last 6-7 weeks, what should you be doing? Well, by this stage, you'll have covered a good chunk of the curriculum. So you want to systematically cover any other gaps and any weaker areas. Then as you get close to the exam, I'd say the last 2 weeks, make sure you've covered, almost everything by then. Carry on, but go over again, i.e. a second time, your stats, your admin, and the high yield clinical topics. Because if you can get a good score, if you can get 80% plus in stats and admin, 70 is enough in clinical, and you'll pass. If you can't get a great score in stats and admin, then you need much more in clinical to have any chance of passing. The last 30 days before the exam, go through our 30-day challenge video. So it's like each one's 5 to 10 minutes. We do one question, rapid review of the relevant guideline. So nice way to cover 30 different topics in the last 30 days leading up to the exam. And then work on your exam technique. So by doing questions, and the last 4 weeks, try to do a full mock in time conditions each weekend, and then go through the answers, explanations, fill in any gaps from anything that's identified from doing those mocks. You can use our AKT curriculum checklist to make sure that you've not missed anything important, and the high yield topics checklist, which we update after each examiner's report comes out, to look at topics that the examiners have highlighted, that these are often tested again and again and again. In terms of resources, if you want to read a specific guideline, you might look up the full NICE guideline or NICE CKS. If you want to cover lots of them quickly and efficiently, our clinical case cards, we've got 112 topic reviews. And there's a digital version, there's a printed version, there's a bundle that includes both. So an efficient way to cover lots of things quickly. Here's some examples. Where relevant, we've sourced and licensed high quality images to cover the topic as well. And then, how we did one question at a time in the first section. And then in the second section, we did a 10-question mini-mock. Our AKT 200 mock crammer course, which runs mid-April, that we'll do the learning in that way, that instead of a 10-question mini-mock, we'll do a 50-question mock. Then I go through the answers, explanations, teachings, and you get a topic review, a PDF little booklet. Then we have a break, then another 50, then lunch, then so on. By the end of the day, we've done 200 questions, more than 200 topics, and they're in the same proportion as the exam. 80% are clinical, 10% stats, 10% admin. But in one long day, you get to review 200 topics and work on your exam technique. So you consolidate your knowledge and work on your exam technique all in one long day. And then after the exam, you get access to a different 200 questions in our online full mock that comes with that. So we've got sort of 3 different things that, for those of you that are now close to the exam, and maybe you've done some of your own revision and you're not on one of our programs already, if you want a boost. So our AKT Pass Plus bundle includes the stats, admin, higher clinical webinars, the AKT 200 mock crammer full day course, but also the full day AKT preparation course that ran a few weeks ago. You get access to the recording of that because that's already happened. 2,700 online revision questions, 3 full mock exams, and our printed clinical case cards. That costs $749, nearly £400 saving compared to if you bought everything separately. Our AKT booster bundle, So that includes the full day 200 mock grammar course, the stats, the admin, the 2 high yield clinical grammar, and 1 full mock exam with different 200 questions to the ones in the course. It doesn't include the case cards. There's about 25 hours worth of learning there. That's discounted at $495 at the moment, about £200 saving. And then our masterclass bundle. So that's learning in the way we learned in the first half. So we've got the stats, admin, and the high yield clinical 1 and 2, all 4 together for $299. That's nearly £150 saving compared to booking all 4 separately. Okay, so those are all coming up in April. All of these live sessions are in April. And if you book any of the live sessions, you get access to the recording for a month afterwards for revision. I leave you, for those that haven't got questions with this, as we come to this last critical period, you've got 7 weeks exactly to the exam today. Muhammad Ali said, don't count the days, make the days count. Don't let a single day between now and the exam pass you by without you making sure that you've done some questions, that you've learned some guidelines, that you've revised something that you looked at earlier, i.e. you're making some progress towards your goal. Those of you on our Pass Guarantee program, we've still got all those live sessions, but we've still got more of these shorter high yield revision webinars to come. And you've also got your targeted revision plans, your individual learning plans in the last month. So cover all of the weaknesses that we've identified from the data we collated from the work that you've done in the first part of the program. Okay, so we've still got lots of learning to come. Okay, so hope you found that helpful. If you've got any questions, please ask them in the Q&A. You can always drop me a message, drop us an email. Our team's here to support you. Whether you join one of our other things or not, our whole team at eMedica wishes you every success. Keep up your hard work, make every day count, prepare, and you will succeed.